Hello and welcome to the HNS Tours Training Curriculum. My name is Sue Yom. I'm a radiation oncologist at UCSF, and I'm pleased to be invited today by the HNS to talk to you about recently completed and ongoing de-intensification trials for HPV-associated oropharyngeal cancer patients. You can see that I have 4 contracts for clinical trials, which are paid to my institution, and I have book chapter royalties and honoraria, which are paid directly to me. So today we're going to go over 4 different ways we can de-intensify radiation therapy and also talk about the strategies of recently completed and ongoing clinical trials. The first way I'm going to show you very concisely is the reduction of definitive or curative intent radiation dosage in the radiation-based treatment setting. So I will show you HN002, which has now fed into HN005 and ECOG 1308, which completed but used a very different strategy of induction chemotherapy for selection. So in NRG HN002, otherwise known as the 60-gray trial, patients who were P16 positive with less than 10 pack years of smoking history up to T3 and 2B by 7th edition were randomized in a phase 2 setting to 60 gray with weakless cisplatin or 60 gray given a little faster, so it finished in 5 weeks. And you can see here that the endpoint of 2-year PFS of 91% was clearly met by the chemo radiation arm, and the IMRT alone arm did well, but had a higher rate of local regional recurrence and a lower progression-free survival at 2 years and did not meet that confidence interval. So the chemo radiation arm from HN002 has been moved forward. And in HN005, which is the ongoing continuation phase 2-3 trial, we are testing the standard arm of 70 gray with concurrent cisplatin against 60 gray with concurrent cisplatin, but with an additional experimental arm of 60 gray given in that slightly accelerated manner with concurrent nivolumab. And if either of those two 60 gray experimental arms meets the interim analysis with an appropriate PFS benchmark, then they will move forward into a phase 3 randomized directly against that standard of care of 70 and cisplatin. ECOG 1308 completed a few years ago, and this is a very different approach. After cisplatin, paclitaxel, and cetuximab induction, the patients were inspected, and if they had a clinically determined complete response, they were given radiation for 54 gray with concurrent cetuximab, but if they had a partial response or stable or progressive disease, they received essentially 70 gray with concurrent cetuximab. And at 2 years, among 51 or 46 patients who had dose reduction because they got dose reduced to either the primary or the nodes, the PFS was only 80%. But more promising in the patients with less than T4, less than N2C, or less than 10 pack years of smoking, those patients had a PFS of 96%, which is obviously much more promising. The ongoing question with this trial is, since the clinical characteristics appeared to be so determinant of response, whether the induction was necessary or whether they just responded well because they had responsive disease to that lower dose of radiation. The second strategy we can talk about, and where I'll show you one recent example, is reducing not so much the dose, but the volume of radiation. So the University of Texas Southwestern just published a trial called the Infield Study. This is a relatively smaller phase 2 where they gave elective radiation dose to 40 gray, then followed it with a 30 gray boost to the gross disease. But importantly, the elective nodal coverage was restricted to only level 2 for the oropharynx and levels 2 and 3 only for the larynx cancer. So the overall volume of the body that was irradiated was reduced. And you can see here that the 2-year risk of elective nodal failure was 0%, showing that this was feasible in the phase 2 setting. The 2-year PFS was only 81% because this was a mixed population, but among those oropharynx patients who would have met eligibility for HN002, the PFS was 90%, which is very confirmatory and similar to what we saw in our study. Okay, now finally, we'll go over the postoperative de-intensification studies, and obviously reducing postoperative radiation dose or potentially changing or reducing the chemotherapy is very relevant to your course today. And I'll show you ECOG 3311, the Mayo Rochester study, and then Pathos, which is currently a phase 3 enrolling in Europe. So ECOG 3311 was presented by Dr. Ferris last year at ESMO conference. And you can see this is an interesting combination of two cohorts and a randomization. Among those patients with low risk characteristics up to T2N1, they were able to have observation. Remember, this is by 7th edition. Among those patients with high risk characteristics, positive margins, or extracapsular extension, or over 4 lymph nodes involved, they had chemo radiation with 66 gray and weekly cisplatin. And then finally, in the middle, over half the patients were able to have a randomization between 60 gray versus 50 gray of the radiation. The outcomes of 2-year PFS were very good across all the arms, and even notably in those patients who required adjuvant chemo radiation therapy, they were still quite good. Important to remember that enrollment in these surgical trials is for surgically eligible patients who have lower stage disease. So in that study, ECOG 3311 up to T2 N2B was enrolled, which is not comparable and very different than the chemo radiation studies we saw earlier. As of now, we don't have direct comparison among these different modalities up front to compare the results. This is another phase 2 from Mayo Rochester, and as you can see here, these patients after TORS received either 30 or 36 gray given twice a day, so that you can get it done faster and more aggressively with concurrent docetaxel chemotherapy. And the 2-year local regional control and PFS were very good in this study as well. This is now being conducted as a phase 3 by this institution. And then in Europe, what I find to be one of the most interesting studies currently enrolling is a phase 2 going into a phase 3 called Pathos. In Pathos, it's very similar to ECOG 3311. The low risk patients are observed. The high risk patients receive chemo radiation, but with a randomization to radiation alone, so testing whether that cisplatin is necessary. And then the middle arms, which are randomization again between 60 and 50 gray. But the key difference here is that this is a phase 2 that is powered to go into a phase 3 with an overall survival endpoint. Okay, and then finally, we should talk about the omission of postoperative radiation. We saw in ECOG 3311 that 11% of the patients were able to be observed. And there is currently a study looking at that early stage population in Europe called the Best of study, which is taking up to that T2N1. Remember, again, this is by 7th, comparing radiation therapy monotherapy versus transoral surgery monotherapy with an endpoint of swallowing quality of life, MDATI, at 12 months. And this is a randomized phase 3. So I've shown you 4 strategies for reducing, for de-intensifying therapy in these patients: radiation dose, radiation volume in the definitive and postoperative setting. And I'd like to make a few closing remarks, which is that, as I stated, outcomes and quality of life have not yet been directly compared between upfront surgery versus upfront radiation-based approaches. And my personal opinion is that the quality of life profile is probably different between these two, but it very much depends on what and how it is measured. Eliminating one or more modalities is desirable, both from a toxicity standpoint and potentially a cost and effectiveness standpoint. And it's important, however, to remember the caveat that de-intensification of radiation really mandates a strong understanding of our history and technique. And selection principles are very critical, just like they are in surgery, because smaller tumors will do better, just like they are in surgery. We share that across our disciplines. I do believe it's important to continue these trials and the phase 3 trials using modern imaging and surgical techniques so that we can precisely test for these potential quality of life and cost advantages. Thank you so much. And please feel free to reach out if you have questions.